Hello, everyone. I'm Dr. Carmen Puliafito, and I'm joined here today. Welcome back to Retina Synthesis, Dr. Paul Hahn of Retina in Nanuet, New York. Paul, welcome.
A pleasure to be here again, Carmen. Thanks for the invitation.
In addition to the wonderful work you do on the PAT survey for ASRS, you gave a very interesting talk that is clinically relevant, which is the role of AR, ARADS microsupplementation effects on geographic atrophy, what we have learned from the Apellis trials, the Derby, Oaks, and Gale trial. Does does ARAD does the ARADS formulation have any effect on geographic atrophy?
That's the million-dollar question. And for a long time, we assumed it did not. In the original AREDS and AREDS2 studies, the impact of those vitamins on geographic atrophy progression was looked at, and there was no impact identified on overall GA growth. But where all this came from was a recent post hoc analysis that was performed by Tiernan and Keenan on behalf of the AREDS and AREDS2 research study groups. And in that post hoc analysis, they reevaluated the impact of AREDS and AREDS2 vitamins on GA growth. So similar to the initial AREDS studies, they found no impact on overall GA growth and no impact on vision loss. But the interesting finding was that in this post hoc analysis of those original AREDS and AREDS2 clinical trials, they did find a positive signal, and that was that AREDS and AREDS2 vitamins could reduce the rate of progression of GA growth specifically towards the fovea. So what that means is patients with extrafoveal atrophy, the component of atrophy that grows towards the fovea, which is of course the most important part, can be diminished or slowed down with AREDS and AREDS2 vitamins. So this was of course a post hoc analysis of that initial AREDS and AREDS2 large clinical trials, but an exciting finding nonetheless. And the goal of the study that I presented at the ASRS annual meeting was to see whether we could replicate those same results in a different data set. So we turned to Oaks and Derby, of course, the pivotal clinical trials comparing Pegcetacoplan versus sham for patients with geographic atrophy. And there are a few notable things to point out about the methodology of the study. Most important is that we tried to replicate the methodology of the initial of that post hoc analysis from Tiernan and Keenan, or Dr. Keenan and his AREDS study group colleagues. So we replicated the study design as much as possible, but there were a few notable differences. The first was the study numbers. So when we think of the AREDS studies and the AREDS2 studies, we think of large studies with thousands of patients. But in fact, most of those patients had earlier stages of macular degeneration and not geographic atrophy that was studied in their post hoc analysis. So in their analysis, depending on which arm they looked at, anywhere from 200 to 500 patients were studied. In Oaks and Derby, of course, everyone had geographic atrophy. And so in the analysis, the post hoc analysis that we performed on the Oaks and Derby trials, we looked at patients from 500 to 1,200 plus patients in those arms. The other key difference was with respect to imaging. So back in the time of the AREDS and AREDS2 studies, which are now decades old, the gold standard for imaging for geographic atrophy was color fundus photography. And that's what was used to document and measure geographic atrophy in the AREDS and AREDS2 studies. But of course, since then, our standard of care has evolved, and we now look primarily at fundus autofluorescence, perhaps with OCT imaging in a multimodal approach, and that's what was used in the Oaks and Derby trials. So with those key differences in mind, what did we find? And back to the million-dollar question, unfortunately, we were not able to replicate those results from that post hoc analysis from Dr. Tiernan and Keenan. Specifically, to reiterate, that initial study from the initial AREDS and AREDS2 studies identified a reduction in growth of geographic atrophy towards the fovea, but in Oaks and Derby, we could not replicate that AREDS or AREDS2 vitamins had any effect on that type of growth. We also could not identify any effect of AREDS vitamins or AREDS2 vitamins on overall GA growth. We looked at vision loss, similarly no effect. We wanted to see whether AREDS and AREDS2 vitamins could modulate the reduction in growth caused by pegcetacoplan or Syfovre. In other words, could ARIDS have a synergistic effect or a harmful effect in the benefits that we see with Syfovre or pegcetacoplan? And similarly, there was no effect on, or no modulating effect with ARIDS or ARIDS2 vitamins. And finally, as we all know, one of the adverse events that we see in association with complement inhibitors and Syfovre is the development of exudative AMD. And we, in this analysis, in this post-hoc analysis, also sought to see whether ARIDS or ARIDS2 vitamins could modulate the effect of exudative AMD as a result of pegcetacoplan. And similarly, there was no effect. And so that's just kind of a long way to say that in our analysis, we were unable to find any effect of ARIDS vitamins on any of our metrics, which was in contrast, and I would say in disappointing contrast, to the effect seen in the initial ARIDS and ARIDS2 post-hoc analysis.
What percentage of the Oaks and Derby patients were on ARED supplementation?
About 40% of patients in the Oaks and Derby were on ARIDS, and there's a high adherence rate, and that really makes Oaks and Derby a trial that's very well suited to examine ARIDS and ARIDS2 supplements.
So what's your recommendation in the real world to patients that come in and many of them have taken these vitamins for years, maybe from early stages of AMD? What do they do now?
Yeah, for a long time, prior to that analysis, when patients who were beyond the so-called high risk, category 3 or category 4 for dry AMD, those advanced AMD patients, I typically recommended not to take ARIDS vitamins. When those results came out, I backtracked a little bit and I said, you know what? I would tell patients that some exciting data just came out and maybe there's some benefits. So if you want to continue them, sure, go ahead. At this point, I've backtracked a little bit the opposite way. And, I think in addition to our analysis, there was another analysis that looked at the lampalizumab clinical trial. That was, of course, a failed clinical trial looking at lampalizumab for geographic atrophy. And there was similarly no effect of ARIDS vitamins seen in that cohort of patients. And so with those two negative results, at this point, I'm not as enthusiastic about recommending ARIDS for that population of patients.
Is there room for further investigation of micronutrient supplementation in advanced AMD or not?
Absolutely. I think the important thing is that each of these analyses are post-hoc analyses, and any post-hoc analysis or the results of any post-hoc analysis should be considered hypothesis generating. So, I think the Tiernan-Keenan analysis identified a hypothesis whereby ARIDS and ARIDS2 micronutrients may be beneficial for GA growth towards the fovea. Unfortunately, our results and another set of results did not replicate that, but it doesn't mean that one is right or wrong. There are different study designs, different nuances to each study, and perhaps a prospective trial would be the gold standard way of designing that. In the absence of replicable post hoc data, I'm not sure whether such a prospective analysis would be performed or whether it would be high yield, but that would certainly be the way to do it.
Well, Paul, thank you for presenting this really clinically relevant information. Thank you.
My pleasure to be here with you as always, Carmen. Thank you for the invitation.